Well, we're here to discuss the American Acne and Rosacea Society expert recommendations for pediatric and adolescent acne management. And we're really quite excited to roll out the expert recommendations and guidelines. First of all, this symposium has been set up by the American Acne and Rosacea Society and in fact is a part of a continuing medical education symposium. This is jointly sponsored by Rady Children's Hospital, San Diego, and Physician Resources. I'm Larry Eichenfield. I'm the moderator and coordinator of the session. And Stacy Moore from Physician Resources is the course coordinator. And this was done in association with the American Acne and Rosacea National Pediatric Acne Guidelines Initiative. This symposium has commercial supporters of Coria Laboratories and Galderma Laboratories, and we appreciate the support. We'd also like to point out that there were other companies that helped to support the guideline initiative process, and that the guidelines were set up as a third-party initiative of the American Acne and Rosacea Society and were not influenced by corporate content in any way. The accreditation for the CME activity is from Rady Children's Hospital, and the CME credit can be completed for 1 hour of AMA PRA credit. I'm very pleased to have really an esteemed faculty with me tonight. Dr. Ann Luckey is Professor of Dermatology and Pediatrics at Cincinnati Children's Hospital, internationally recognized expert in acne. And Tony Mancini is Professor of Pediatrics and Dermatology at Northwestern University and Children's Memorial Hospital and head of the Pediatric Dermatology section. So the background to what we're doing tonight is that the American Acne and Rosacea Society is a group that's dedicated to acne. And we realized, along with a group of pediatricians and pediatric dermatologists, that acne is an important issue throughout the pediatric ages, yet there really weren't specific expert recommendations or guidelines for the management of acne. So I'm very pleased that we have an exceptional faculty tonight with Ann Luckey, who's a professor of dermatology and pediatrics at Cincinnati Children's Hospital, and Tony Mancini, professor of pediatrics and dermatology at Children's Memorial Hospital and Northwestern Medical Center. And the three of us are going to go through some basics on acne. I'm going to start off with the acne, introduction of the acne guidelines, basically the why we went about coming up with expert recommendations, the how and the what. So let's start off with a few faces of pediatric acne. And you can see there's a range in terms of the type of acne we see as well as the age, with some infants included, as well as some pre-adolescents. There's an 8-year-old image that's there, as well as some adolescents as well. So the sort of questions that were behind our desire to really give some insight about pediatric acne included in the first few years of life, when is acne transient and nothing to worry about, as compared to when is it significant and need to be treated? Another question is, when do I need to work up a young child with acne? If you have a 3-year-old present with acne, do you need to worry about some pathology associated with that acne? How about in an 8-year-old or a 9-year-old? Is that just early pre-adolescent acne, or is it something that could be pathogenic? When do you need to work it up? In a 9-year-old, what treatments are appropriate? We're going to discuss some of the regimens of care that are appropriate for 9-year-olds, and is it any different than in an adolescent? And then as we see more significant acne here, brings up the question of what's the appropriate use of oral antibiotics in pediatric-aged patients, and which antibiotics should you use, how should you use them, and for how long? And lastly, in our most severe acne types, what about isotretinoin? Is it okay to use in pediatric patients? So the background, we know that acne is common in the pediatric and adolescent age group, that there aren't specific acknowledged guidelines of care or expert recommendations for the management of acne in the pediatric age group. We know that the presentations of acne and the differential diagnosis can be different at different ages. And clearly there's a strong desire to increase recognition and improve the management of acne across the spectrum of both primary and specialty care. So what was done is there was really a unification of efforts from pediatric dermatologists, and pediatricians from the American Acne Rosacea Society, as well as a group known as the Acne Alliance of North America. And both myself and Diane Tibitu got together and set up a distinguished panel, which was really a mixture of dermatologists with expertise in acne, pediatric dermatologists with acne expertise, some general pediatricians, as well as some junior pediatric dermatologists who served as expert reviewers of some of the data. And so this is a list of the panel members. You can see some very accomplished figures in both acne and in pediatric dermatology. And the group had a process where the goals of the guideline process was set up, including a desire to set up a variety of educational initiatives, of which this is one. We had comprehensive literature review of the topic areas with assignment of specific reviewers based upon certain questions that we had. We had faculty leads for each specialty topic area, and the data was reviewed. There was a series of conference calls, small group meetings, and a final meeting with topic presentations by faculty, as well as the development of a treatment algorithm for children, depending upon the acne type and severity. So what did we do in terms of the expert recommendations? This slide is a variety of the material that was put together for this initiative, and we do not have time tonight to go through all of them, okay? Because we included evaluation of acne by age and classification, which I'll discuss briefly tonight. Diet and acne, we don't have the time to get into it all, though it'll be in our publication about this. Over-the-counter products, topical retinoids, antibiotics, and topical combination products, as well as topical benzoyl peroxide will be discussed tonight in relationship to algorithms and management of pediatric acne. Oral antibiotics, some of the age issues and safety issues, isotretinoin in pediatric patients, hormonal therapy, and then algorithms for care of both adolescents and pre-adolescents. When we talk about acne in terms of age, this is the age classification that we will be using. Generally, there's neonatal acne, 0 to 6 weeks, infantile acne that can develop even in the first few weeks, but generally in the first few months of life, lasting up to a year generally. Mid-childhood acne, generally presenting from a year to 7 years of age. Pre-adolescent acne, at 7 to 12 years of age, which is generally like adolescent acne. It's just occurring before the typical age of adolescence and increasingly common. And then adolescent acne, which we've defined as 12 to 19 years of age. We will not be discussing neonatal or infantile acne tonight. What I did want to stress, however, is that when it comes to evaluation or workup, if you have a child with mid-child acne, meaning presentation of acne at 1 to 7 years of age, that's the most likely patient to have an underlying endocrine abnormality, and a workup is appropriate. And in further discussions and documents and publication of the guidelines, there'll be details about appropriate evaluation and management of the different age groups for pediatric patients with acne or acne-like conditions. So usually there's no need for hormonal work in pediatric acne. However, in those patients who may be at risk for this, especially those 1 to 7 years of age, there's a certain presentation in terms of how we like to evaluate those patients: height, weight, growth curves, blood pressure, signs of sexual maturation. And then in patients at any age whose acne is unexplainably resistant to treatment, it's reasonable to consider an endocrinologic workup or referral to pediatric endocrinology. Pediatric acne grading and classification, simplicity is generally the key. We like a fairly simplified approach to the descriptions of lesions, and Ann Lucky's going to go through what the classification is tonight. But we also like an assessment of the presence or absence of scarring and pigmentation, and the impact of the acne on the individual. A simplified classifications are general approach, where we look at acne and say, is it predominantly comedonal? Is it comedonal and mixed? Is it nodular or cystic? And then is it mild, moderate, or severe? And using this simplified classification and the algorithm, we can generally approach good initial and subsequent manifestation of most of our patients. Dr. Lucky is going to review our treatment armamentarium. When it comes to pre-adolescent acne, actually, there's much more off-label use than on-label use because there's a minimal number of studies in children under age 12. And the regimen includes over-the-counter products, including benzoyl peroxide, the retinoids, antibiotics, and combination therapy, oral antibiotics, isotretinoin, and hormonal therapy. There's also algorithms that'll be presented tonight, and we're going to work through some cases in terms of the algorithms. And the algorithms are the same if someone's a dermatologist or a pediatrician or other primary care practitioner. And actually, the algorithms are the same for the pre-adolescent patients as they are for the adolescent patients. And the recommendations are really based on an analysis of multiple studies. So I'm just going to briefly show the examples of the algorithms. The algorithms basically say, is the acne mild, moderate, or severe? Mild acne, whether it be comedonal or inflammatory mixed acne, can be approached with initial treatment as an all-topical regimen, either with single agents, benzoyl peroxide or a retinoid, or with combination therapies. If there's inadequate response, we move over to this side of the diagram, and then you can add that which isn't added. For moderate acne, whether it be comedonal or inflammatory mixed acne, you can start with an all-topical regimen, or in more severe moderate cases, you may use an oral antibiotic and topical agents. And then the inadequate response, you'll add what's necessary, and Dr. Mancini will go through this in greater detail. And for severe acne, we're generally going to start with an oral antibiotic plus a topical regimen that's usually including benzoyl peroxide for reasons to minimize resistance to the antibiotics being used. And if there's inadequate response, we can consider the change and or the use of isotretinoin or hormonal therapy. And for the primary carers in the audience, the consideration of dermatology referral as well. So that's sort of an orientation to the general presentation. And at this point, I'm very pleased to invite Ann Lucky, who's going to discuss the acne basics, diagnosis, appropriate treatment, and factors influencing therapy. Ann?
Thank you. Get the next slides. No. We can put up the next slides. Anyway, what I'm going to do is to review a little bit about the pathogenesis of acne, which should help us understand the different two basic types of acne. And the factors in acne really are several. There's bacterial infection with P. acnes, and treatment is really mainly in the antibiotic category, whether that's topical or systemic. There are keratinization defects, which are approached with retinoids. There's an inflammatory reaction to the bacterial infection, and that's an area that really needs some work because we don't have a lot in our therapeutic armamentarium for the inflammatory reaction, but there is a need for that. And then there's a hormonal component, which is the excessive sebum production, which is promoted by the male-type hormones or androgens, and for that, hormonal therapy. And as Larry said, that we very simplistically divide acne into non-inflammatory and inflammatory lesions. The non-inflammatory being open and closed comedones, the inflammatory being papules, pustules, and nodules. And then for each type, you would then look at the severity, mild, moderate, and severe. So you look for your comedonal acne, is it mild, moderate, and severe, or your inflammatory when you're choosing your treatment regimen. These are little pictures of what is actually going on in the skin with acne, and normally we have these little sebaceous follicles, which are specialized hair follicles with lots of oil glands, and when they become filled with keratinocytes and then the little blue spots are the bacteria, they are can form comedones. And the difference between a closed and an open comedone, and you'll see that clinically, is just the size of the opening. So there are things that are in the middle that's hard to classify whether it's closed or open. But these are all basically outside the body, and these don't scar. In order to get a scar, you have to do something down deeper in the skin, in the dermis. And so inflammatory acne may start with a closed comedone, and then there's inflammation, and you can see that this barrier that used to go all the way around is now breached, and there are all kinds of inflammatory cells. Now, if those inflammatory cells cluster at the surface, you get a pustule. And if they're just inflamed under the skin, you would get a papule. Nodules are just collections of papules or pustules that breach more than one follicle, and more than one follicles involved. So just going through those clinically, what are closed comedones? They're 1 to 2 millimeter firm, white to flesh-colored bumps. You can feel them, sometimes even more easily than you can see them. And some of them actually may have small dark centers, and some of them, it's a toss-up whether you'd say open or closed. They do not scar because the bottom part of the skin is not involved. And here would be a typical picture of a fairly young child with lots of little open closed comedones. Open comedones are commonly known as blackheads, and they're, again, about the same size as closed comedones, but they have larger black centers, and they're on a continuum. These central plugs can be expressed, but if you've ever done it or seen it in a patient, the black is just on the surface, and the rest is kind of a skin-colored collection of cells and lipids, and it is not dirt, as most parents think. They try to get their kids to scrub away their blackheads, and you really can't scrub them away. These also do not scar. And here, for example, is a girl who has multiple open comedones. This is actually a very common place to have them early in acne, is in the ear. Now, papules are the red bumps on the skin. They also are palpable, and that's the way you can tell the difference between that and an old lesion, which would be just a scar. They may or may not be tender. They may arise from comedones, and they are part of the papules, pustules, and nodules, so they can become pustules, or they may have been pustules, and they can change. They resolve with post-inflammatory pigmentation, which could be red or brown depending on skin type. And any kind of papule does have a potential for scarring because it's down in the dermis, in the second layer of skin. If we can advance. So here would be a typical child who now has some comedones in the background, but mainly red papules on the surface. Pustules are similar, and both papules and pustules are up to about half a centimeter in size, and when they have a little cap of pus on the surface, when they rupture, they become a papule. They usually are much fewer and more transient than papules, and they also have a potential for scarring. So in this girl, you can see down here all the little white centers on the pustules. Finally, the nodules, they're 5 millimeters or greater, and they're red, they stick out, and they're often very tender. They involve more than one follicle. And we used to talk about cystic acne, but that was actually quite confusing because cysts have a true epithelial lining, and nodules don't. They're just inflammation. These have a great potential for scarring. Sinus tracts, I'm going to show you, look like nodules, but these do have true epithelial linings. And so here's a young man with quite a few large nodules, and each one is surrounding multiple sebaceous follicles. These are sinus tracts. They look very different, and these are treated in a different manner that we're not actually going to discuss today. They're fairly rare. Now, what are our treatment options? Well, we have conventional therapy, and that would be topical therapy, that's antibacterials and retinoids, or systemic antibiotics. We have Isotretinoin and hormonal therapy. And finally, we hope that we will have anti-inflammatory therapy, but not much on the horizon right now. Now, really the first line that our patients encounter in acne treatment are over-the-counter topical medications. And when, as a dermatologist, patients come to me, almost every one of them has tried at least one product and sometimes multiple products. For very early disease, very mild disease, these may be effective and well accepted. And the main things that you'll find over the counter are benzoyl peroxide in various concentrations, salicylic acid, but also sulfur compounds, alpha hydroxy acids, and herbals. And we're not going to discuss these. There is very little evidence surrounding those products. There are also adjunctive treatments, and patients love these products. They give them a sense of control over their acne, although their effectiveness is a little bit debatable. And I usually agree with my patients that it's okay to use them as long as they're not doing anything harmful. And these would include your washes, scrubs, masks, abrasive astringents, and you do have to be careful because some of these may actually do some harm. Pore cleaners, cover-ups in cosmetics, and for example, a green base to cover the red colors, and then recently some vibrating and heating devices that are extremely popular in the pediatric age group. Now, there are other modalities not being discussed: pulse dye laser, photodynamic therapy, and in Europe there's a 5-lipoxygenase inhibitor. These are all very high-cost treatments, and you'll hear about them, but really are outside of the range of our normal therapeutic armamentarium. In more detail, we would look at what we do for inflammatory acne and what we do for comedonal acne, and the products in yellow are the ones that I would preferred and probably the most well-tested products, although there are other products on the market. Benzoyl peroxide has been around for a very long time. It's antibiotic and maybe anti-inflammatory, 2 to 10% in a variety of vehicles, and currently all pure benzoyl BP products are over the counter. Its probably biggest disadvantage from the teenager's point of view is that it tends to bleach things, and it's always good to warn your patients. Topical antibiotics also initially work well for acne. Erythromycin and clindamycin are the two that have been marketed the most, but you'll hear me say this many times, they're not recommended to be used alone because resistance is very easily induced, and when you have them often in combination, as we'll see, you have less chance because the benzoyl peroxide will reduce the number of resistant bugs. Recently, topical dapsone gel has come on the market, and this is both anti-inflammatory and antibiotic and has a niche in patients who may not be able to use benzoyl peroxide, for example. Now, for comedonal acne, the mainstay is retinoids, and there are 3 classes of retinoids available: tretinoin, adapalene, and tazarotene. And there are a variety of both brand name and generic products for tretinoin and adapalene. And as you can see, a variety of concentrations and a variety of vehicles. And it just takes a little experience, and you would decide, which of these is best for a particular patient at a particular time. Tretinoin is kind of the middle ground. Adapalene tends to be a bit milder, and tazarotene tends to be a little bit harsher on the skin, but also tends to be a little more effective. So these are the choices that we have in treating comedonal acne. Now, there are a variety of combination products with benzoyl peroxide and erythromycin. That was the original combination. That does need refrigeration and has a shorter shelf life. There are quite a few benzoyl peroxide and clindamycin products on the market, which have variable shelf lives. Benzoyl peroxide and adapalene is a fairly new product, and the only one that actually has a retinoid and anti-inflammatory together. Clindamycin and tretinoin would be your antibiotic and tretinoin, and many clinicians will use benzoyl peroxide in addition at another time. And then, again, the combination may prevent resistance. And these products are very elegant, very nice, very expensive. And with insurance, sometimes it's very difficult these days to be able to use the products that we would like to be able to use. Systemic acne therapy, we have three major classes: antibiotics, isotretinoin, and hormonal therapy. And just a few words about antibiotics. It's usually a good idea to try topical therapy unless the patient presents with severe disease or fails topical treatment. We tend to limit the time on oral antibiotics to 3, 4, sometimes 6 months, and promote topical treatment to minimize bacterial resistance induced by the oral antibiotics. And then some of our patients can't swallow pills, and so we have to be a little creative in using liquid preparations, crushed tablets, or sprinkled capsules to get them to actually be able to take them. The cyclines are the mainstay of therapy. That's tetracycline, doxycycline, and minocycline, and they cause tooth discoloration before age 8, but the enamel is fully laid down by age 8. They can cause GI irritation, rarely can induce pseudotumor cerebri, and are very sensitizing, so you must emphasize good sun protection because you can get into trouble, especially in the summer. Minocycline in particular is an excellent antibiotic, but there are some allergic reactions, autoimmune hepatitis, and lupus-like syndromes that can be induced, especially with long-term use, as well as pigmentation. Now, there are other antibiotics listed here that work well for acne, but these are often antibiotics that we would use for other systemic treatment. And in treating acne, you're also running the risk of resistance to all the bacteria in your body, so we tend not to use those as first-line therapy. Isotretinoin is a drug that is primarily prescribed by dermatologists. It's a derivative of vitamin A, and the very first product was called Accutane, although interestingly enough, that original brand name is no longer available. So there are 2 or 3 generics that are used. These can be used in younger patients at the same doses as in adults, and it's based on weight. But with certain considerations, such as the effect on bones, there can be some effect on bone structure, how to deal with pregnancy prevention in young girls, especially girls who haven't started their periods, and teenage girls who have to get into the whole conversation about contraception. There has been some concern about depression, and recently more concern about inflammatory bowel disease. And finally, these younger children probably have a higher incidence of relapse after isotretinoin than older patients who tend to kind of outgrow their acne at a certain age. For example, this is a 13-year-old girl before and after treatment with isotretinoin. It works very well in usually about 6 months, and about 70% of patients clear up and stay clear. So it is often a very good choice, but very tricky to administer. Hormonal therapy, the most common one is oral contraceptives, and this applies to girls only. It is useful after menarche, glucocorticoids for certain adrenal abnormalities, and then antiandrogens like cyproterone acetate and spironolactone, but we're not going to be discussing those here. There are several combination oral contraceptives that are approved, and it's really important to realize that progestin-only contraceptives can actually worsen acne. It's really the estrogen component in the combination that helps. And because premenarchal girls are not at risk for pregnancy, and estrogen may accelerate epiphyseal closure and affect ultimate height, we really, are in a little bit of a bind, even when we suspect hormonal considerations in younger girls. The decisions are really between gynecologists, parents, and the patient themselves. The word on the street is that the pill makes you fat, which is actually not true. Some get fat, some get thin, most stay the same, but it is a barrier to use, and if compliance is issue, patches rather than oral daily pills often work. But often in girls, hormonal therapy may prevent the need for isotretinoin. And here's a young woman was referred to me for isotretinoin. We put her on the pill for contraception, which we need with isotretinoin because of birth defects. And she maintained throughout the rest of her adolescence on oral contraceptions, combination oral contraceptives, and did very well. I think that we need to put in a word, and Larry talked about the considerations that are different in the pediatric population. Adherence is the biggest problem. Less than half of my patients actually do what I tell them or ask them to do, and you find that out by asking them what they're doing, and they may not comply, but they're usually honest. Many are influenced by marketing and by what their peers are doing, and often they're brought in by their parents and are really not motivated to treat their acne, especially the younger children. So this can also become a major contentious issue between the parent and child. We need to make our regimens simple. Once daily treatment, if they can't do things morning and night, even alternate every other day. Easy to use products, things on pads or in pumps are very popular. And don't give them too many products, like 1 oral and 2 topical is probably maximum. Don't be judgmental. Don't ask, do you use your medicine every night? They'll all say yes. You should say, oh, how many days in a week do you really get a chance to use your medicine? Then they know that they could tell you, well, I don't use that one, or once or twice, and then you try to find out, if they don't like it or if they're just having problems. Listen to your patients. You really want them to think that you're on their side, not the adult enemy. Find out what they like or dislike, smell, texture, etc. Discuss their expectations. Will they be clear for prom next week? They all want instant perfection, and you have to explain that this is a slower process. And then just create a bond with your patients. Speak to them, hand prescriptions to them, show interest in issues that they're interested in, and they really will give you a little more credibility, as teenagers are naturally suspicious, and maybe even follow what you tell them to do. So the considerations in choice of therapy, besides knowing what therapy, knowing what kind of acne you have, is previous treatment and the previous history, costs, vehicle selection, the ease of use of the regimen and how complex it is, what side effects you're facing, and of course the psychosocial impact of acne, especially around the issue of scarring. So treatment is tailored to the type and severity of the acne. The treatment of the younger patient is really based on the same therapeutic principles as in older patients, but understanding a pediatric approach to the delivery of care is important to achieve adherence. Thank you.
Thank you, Anne. Next, we have Tony Mancini, who's going to discuss an overview of the acne algorithm and applying it in practice.
Thank you, Larry. Okay, so we're going to spend the next 20 minutes reviewing the acne algorithms that Larry already introduced in a little bit more detail, and we'll look at the mild, moderate, and severe algorithms. And then I'm going to actually go over some case vignettes with photographs of patients, and we'll look at some typical potential approaches to those patients, and I'll open it up as a discussion with Drs. Eichenfield and Lucky at that time. So Larry showed these slides earlier. Let's look at the mild acne algorithm again. So here we're talking about patients who have comedonal acne or perhaps mild inflammatory and comedonal acne or mixed acne. And on the left-hand side of our algorithm, you can see initial treatment recommendations. And in here in the upper box, you would notice benzoyl peroxide or a topical retinoid, both of which would be appropriate Many acne experts would recommend a topical retinoid, though, as a preferred initial choice of therapy because of its great effect on breaking up existing comedones, or comedolysis, as well as prevention of new acne lesions. These are topical therapies, obviously, we're looking at initially here on the left. Other potential approaches, say the patient has a few inflammatory lesions, would include topical combination therapies, such as fixed-dose combinations of benzoyl peroxide and an antibiotic, or a retinoid and a benzoyl peroxide, or perhaps all three, a retinoid, antibiotic, and benzoyl peroxide. You see here in smaller print the topical dapsone in this setting could be considered as a single therapy or in place of a topical antibiotic in this algorithm. I want to highlight that you'll see on each of the algorithms the considerations box, and Dr. Lucky just went over this, but these include each time you see the patient, both at initial visit and at follow-ups, considering things like their previous treatments, the history of their acne, the costs to the patient, and obviously their insurance coverage, vehicle selection, which we all know does make a significant difference in tolerability and efficacy of many acne therapies, ease of the use, and highlighted the importance of adherence, and clearly that's a challenge we all face in dealing with the typical adolescent acne patient. Side effect profiles, the psychosocial impact, which is obviously very important and is always at play to some extent in adolescents who have acne, and then the risks of scarring, and again, trying to keep the regimen as simple as possible. So that same box appears on each of the algorithm slides, and these are the things that should be going through your mind as a clinician when you're seeing the acne patient and coming up with a therapy. So let's say that you use one of these initial treatments on the left, though, and treatment is not adequate. The first thing always to consider that you see down here in the lower right-hand corner is assess adherence. And again, Anne said something that I really agree with, that the acne patients often aren't all that adherent, but they tend to be honest for the most part in the clinic. And I reinforce that. I thank them for their honesty. And instead of phrasing the question as, are you using your treatment, I phrase it as, tell me how many days a week you forget it or don't use it. And they'll usually be the first ones to come up and say 2 or 3 times a week, I don't even use it. So always assess adherence and think about ways that you can improve that. And then you can look at the right side of the algorithm, other options, which would include adding the missing ingredient. Maybe you don't have a benzoyl peroxide or a retinoid on board, so you can add that to what you've already prescribed early on. Or if you've already prescribed a retinoid, think about the retinoid you're using. Different retinoids have different strengths, as Dr. Lucky pointed out, and you might want to change the concentration, the type, or the formulation. And then you also may want to look at the fixed-dose combination regimen that you're using, and you may want to change to another one of those options. Moderate acne, so patients who have both comedonal and inflammatory lesions, and I really think of moderate as quite a range. Some patients are more towards the mild end of moderate, and others are really heading more towards that severe end of acne. So we'll look at 2 different therapeutic vignettes under this algorithm. So initial treatment on the left, looking at topical therapies first, would include combination therapies, perhaps a retinoid plus a benzoyl peroxide, or you might consider a fixed-dose combination of benzoyl peroxide and an antibiotic, but adding a retinoid because you really want the comedonal lytic effects, or a fixed-dose combination of a retinoid with an antibiotic and adding the benzoyl peroxide. Remember that benzoyl peroxide, really, really important to have on board with almost every patient who's being treated for acne, especially if there's an antibiotic as part of your regimen in an effort to decrease the risk of antibiotic resistance. If the patients are more towards that severe end of moderate, then you'd consider addition of an oral antibiotic at the get-go along with your topical regimen. Again, hopefully a retinoid and benzoyl peroxide plus or minus an antibiotic topically. I will say that, again, most acne experts really try to recommend that if you're treating with an oral antibiotic, you try to avoid the use of a topical antibiotic, but things don't always work out perfectly, and it depends on which fixed-dose regimen the patient may like, and often we do end up treating with both a topical and oral antibiotic. If there's an inadequate response, then we can look over at the right side of the algorithm. We might consider the retinoid again that we're using and changing that retinoid or the formulation, or a change in the topical combination therapy. And if that doesn't help us out, then we might look at the oral antibiotic and changing to a different class of oral antibiotic or adjusting our dose. If we're dealing with a female, we might really consider hormonal therapy here, things like combined oral contraceptives or spironolactone if it seems appropriate, or consideration for oral isotretinoin. And you see here in red, consider dermatology referral. So for the primary care practitioners in the audience, if you get to this point and you're really not having success, it's a very appropriate time to consider referral to a dermatologist. And again, just to highlight, assess adherence is the first thing to think about when they come in with that inadequate response. And then severe acne. Here we're talking about patients at the end of the spectrum with inflammatory lesions. Often these patients have nodules and may already have evidence of scarring at the time you see them. So really here on the left side, initial treatments, most would recommend a combination regimen, which includes an oral antibiotic, as well as the topical regimens we've talked about. A retinoid and a benzoyl peroxide would both be ideal. The retinoid in an effort to treat the existing comedones, but also to prevent future acne lesions, and the benzoyl peroxide in an effort to decrease the risks of resistance. And you could consider, again, a topical antibiotic depending on the patient. In this algorithm, notice that the considered dermatology referral is mentioned right at the initial treatment phase. And I think for most pediatricians, when a patient walks in with severe cystic or nodular acne, really referring to a dermatologist is an appropriate first-line response. If there is an inadequate response to the regimen we've talked about on the left, then you come over here and consider, again, a change in the oral antibiotic or consider oral isotretinoin. And again, in females here, we might consider use of a hormonal-based therapy. So let's look at some case vignettes. And I want to just point out a few things. These are obviously examples of treatments and treatment combinations, because as you've seen from Dr. Lucky's lecture, there's a variety of agents out there available to us in our toolkit for treating acne, and hence if you put these together, there's multiple different ways to combine these regimens. It's important that we understand classes of agents and what we're treating and think about the pathophysiology of the acne and then try to create an effective care plan, but one that also keeps it as simplified as possible to increase adherence. And I have shown trade names in the following vignettes, and that's because it really helps, I think, in recognition of the products that are out there, especially for the primary care practitioner. So mild comedonal acne, here we see on the left panel primarily open comedones, and on the right side primarily closed comedones. So appropriate treatment choice for a patient like this might be a benzoyl peroxide cleanser, or personally I'd probably prefer a topical retinoid in this setting, again in an effort to get rid of those comedones and as a maintenance regimen to prevent more acne. Some might jump right to a combination regimen of a fixed-dose product, such as Acania. Acania listed here is a combination of clindamycin and benzoyl peroxide with Atrilin gel, a formulation of topical tretinoin. Ann and Larry, do you want to comment on any other different approaches or recommendations you might have for these patients?
Well, the considerations come into play here. If a patient comes in having been on over-the-counter products, you need to check out which ones they are. Sometimes they're on nothing, sometimes they're on salicylic acid, sometimes they're on a benzoyl peroxide agent. If they're on benzoyl peroxide over the counter, then I'm not going to start with just benzoyl peroxide, even though that's one of the first line, because essentially I'm doing first line of therapy in my hands. I'll probably go to something like either a topical retinoid or one of the topical retinoid combination products, because it's almost like second line, even though it's first line for me. And there's certainly many options of good both individual retinoids or some of the retinoid combinations.
I'd just say for the non-dermatologists that the choice between cream and gel really has to do with the gels tend to be more effective but also more drying than the creams. Now some gels will have moisturizers in them, and some are better than others, but in general, that may help you make your decision about what vehicle, because it's very daunting when you look at the long lists of percentages and vehicles, but in general, the gels are a little bit stronger than the creams.
Although certainly. The newer gels,
are better.
Drying. They can even be hydrating to a degree, so there's some.
Yeah, there are some exceptions.
Yeah.
Great points. And actually, I really highlight what Dr. Eichenfield said about considering what the patient's on. We assume often that when they come into our office to see the physician that they want to change, but sometimes they just want permission to use what they're already using, whether it's proactive or whether it's a store-bought product. And if they have mild acne, we know that these contain appropriate ingredients to treat mild acne, so it is okay.
One other thing, many of our patients like these regimens that they get over the counter that has washes and toners, and very often if you don't take it away from them, you would just substitute and say, well, at night, instead of using the nighttime one, try this prescription product, and then keep using your wash that you like and your toner, whatever a toner is. We missed toner somehow in our education. But I would say you don't take it away, because you want to make them feel like I often leave the choice of a cleanser to the patient. I'll say, well, you should just use what you want because it's not going to make a huge difference in how well your acne is going to do. Let them feel empowered.
And the other factors, lastly, at least from my standpoint, is that the considerations box there really talks about cost, vehicle selection, ease of use, and we have to really figure out what'll work to the degree for the individual. Don't want to make it more complex than it is. It's nice that you have some choices in the different boxes in terms of the combinations, but you also want to know what's covered for that patient, and again, trying to keep a regimen simple. Many times some of the combination products will have an advantage. You can get 2 different classes of medicines in the same tube. If you can get that patient something, that can be very cost effective if once a day they're getting 2 types of medicines as compared to dividing them up.
And while we're having this discussion, it's a good time to mention the real utility of written action plans for acne patients, whether you're a pediatrician or a dermatologist. Really, the acne patient should not leave your office without a written action plan. And those of us who use the electronic record, these are really easy to develop now. Use your smart field so you can just plug in the right drugs in the right places, and they go home with a list they can post on their fridge or in the bathroom, and they know what to use and when to use it. So very, very useful. Helps increase adherence. So mild to moderate acne, here we're looking at patients who have some combined type lesions. You see inflammatory papules as well as closed comedones, but more towards the mild end of the spectrum. So let's look at our moderate acne algorithm. And for a patient like this, an appropriate start might be a combination product such as Epiduo Gel. This is a combination of a retinoid and benzoyl peroxide, which would treat both the inflammatory lesions and the comedonal lesions. Or another fixed dose combination like Zyana Gel. This is a combination of an antibiotic and a retinoid, but here we want to add the benzoyl peroxide product because there's an antibiotic on board and we want to diminish resistance. Another choice would be a different fixed dose combination. Just to try to give examples here, Duac Gel. So here we have a combination of an antibiotic and a benzoyl peroxide, but we're adding the retinoid ingredient. So again, we're covering all of our bases with therapy. This patient, let's assume for now, has primarily facial involvement. We'll look in the next slide at patients who may have more truncal involvement. Larry, Ann, I'll open this up to you.
Well, you have a choice in this you have to decide how moderate is the acne. We're only looking at the forehead, and if the same density of lesions was all over the face, I might say that's more on the moderate, severe moderate, and then I'd probably have a discussion with the patient about how much they cared about their acne, if it was having an impact in terms of their lives, and also their speed of response, because there's an option. The top box gives you an option of an all-topical regimen, and that can probably get 60, 70% under control in a few months. The bottom is an oral antibiotic, plus a topical retinoid with the addition of benzoyl peroxide or a combo. And the oral antibiotic may be a little quicker in terms of the response for your more severe acne. It may also have a benefit if there's truncal involvement as well. However, it's taking on a different kind of risk with a systemic therapy. Generally very well tolerated in the adolescent age group, but that's just one of the issues that I discuss with them in terms of making that decision.
I also think history is very important here because you'd have a different approach of someone you've been treating for 3 months and someone you've been treating for 9 months. And when you get to the 9-month, you're much more likely to go rapidly to the right-hand side. And for girls, for example, this is where you might, after you've been on oral antibiotics, go into hormonal therapy, which can be very, very useful. So I think.
And the other thing I'd like to say is that the expert panel was pretty clear, or most acneologists are clear, that we don't like to use oral antibiotics alone.
No.
So if you're going to use an oral antibiotic, you need a topical retinoid or a topical retinoid combination in the regimen of care. The antibiotics alone are considered substandard therapy right now. So that's why it's not listed as its own thing.
And along the lines of this patient and oral antibiotics, the other thing we have to consider that's really not in our considerations box, but is parental preference. And parents often do end up driving the choices here, and antibiotics are a concern to them frequently, oral antibiotics. You know, they know what they read, they're worried about flesh-eating bacteria, they're worried that antibiotics chronically cause cancer, they're worried about resistance. So in a patient like this, I often will have this whole discussion, but give them the topical regimen to start off, give them that prescription for the oral to hold on to, let them think about it, say, see how it goes in 4 to 6 to 8 weeks. If we're not seeing improvement, then you can start that oral antibiotic. And it gives them time sometimes to go through the thought process, get their questions answered, and then they come around to allowing it. Now, the patient who has significant scarring, of course, I'm going to be a bit more aggressive in the clinic setting, trying to impose upon the parent how important it is to treat more aggressively right off. So here we're looking at more, again, moderate acne, slightly higher end of the spectrum because let's say these boys also have truncal involvement, so chest, shoulders, and back are involved as well. You can see a fair number of inflammatory papules and pustules, and there's also admixed open and closed comedones. So going back to our moderate acne algorithm, let's look at some options. The first choice here would be for the patient who has this face but maybe doesn't have significant truncal involvement, and it's very similar to what we just discussed. Here we have a fixed-dose combination product. In this case, I chose benzoyl gel combined with a topical retinoid like Differin 0.3% gel. So you're covering your BP, your antibiotic, and your retinoid. But let's say there is more truncal involvement, then the second and third choices would probably be more appropriate as first-line starts. The second one, using a benzoyl peroxide wash along with a topical retinoid like Tazorac, and here adding oral minocycline as a systemic antibiotic. Or another option, Epiduo gel again, which combines the retinoid and the benzoyl peroxide with oral doxycycline. Multiple ways you could approach this, multiple combinations. I know Dr. Lucky, for example, still uses quite a bit of tetracycline. Maybe Anne, you can comment on that.
Yeah, I think there are major cost considerations, and we're talking anywhere for under $10 a month all the way up to over $700 a month for the cost for an oral antibiotic. So insurance coverage, and philosophically some people feel even if insurance is covering it, eventually those high costs will come back in higher insurance premiums, so that cost containment has become, and I say with more and more of our patients having health savings accounts and actually seeing what's being paid, that's a big consideration for our families.
I think we customize according to what regimens we think will work for families as well, because there's also a range for the oral antibiotics between a Q-day or BID dosing for different medicines. And then, of course, depending upon whether you're giving them one topical or multiple topicals, realize that, especially when it comes to busy adolescents, take someone who's a junior in high school, you have to be very careful to have a time-efficient regimen, otherwise they're not going to be able to really manage it.
All right, thank you. And then severe acne, the end of the spectrum here, you can see these patients both have large numbers of inflammatory lesions with nodules and already evidence of significant scarring. So looking at our acne algorithm for the primary care provider, you'd really be into this area, which is considered dermatology referral, be absolutely appropriate if you yourself don't prescribe isotretinoin. There is something to be said for giving patients like this a trial of traditional therapy. Now, this one's a little bit on the severe end of the spectrum, but we're amazed sometimes at patients that have moderate to severe acne, how well they may respond to a more traditional regimen of, again, as I listed here, benzoyl peroxide, a topical retinoid, and oral doxycycline. That's also something you can get going while you're awaiting referral for the primary cares in the audience to the dermatologist, understanding that, of course, they'll have to be off the tetracycline for a couple of weeks before starting oral isotretinoin. But oral isotretinoin is probably going to be the treatment of choice in a patient of this degree of involvement. Larry?
I still think that most everyone will start an oral antibiotic before isotretinoin. And that's a standard recommendation. Many times that's something that's necessary from an insurance company standpoint as well. But I think it's also good for the acne because there's some anti-inflammatory effects to doxycycline, minocycline, or some of the other antibiotics that will allow you to transition a patient into isotretinoin more easily. So I think it's really an important first approach, even for the severe acne.
Yeah, and even though the pediatricians don't deal with this, if you treat very severe acne with standard doses of isotretinoin, you tend to precipitate a much worse flare. So it's paradoxical, the worse the acne is, the more careful you have to be in starting with tiny doses and often combining that with systemic steroids. But these are really sort of difficult technical things. So if you can get the patient as sort of calmed down as possible with the antibiotics, you have a better chance of not getting into more trouble with your isotretinoin.
And when I see referrals for isotretinoin who are on antibiotics and then stop them because they didn't work, I'll reinitiate them as we're getting set up to start patients on isotretinoin.
But obviously the concern I mentioned with tetracycline class antibiotics and isotretinoin would be the increased risk of pseudotumor So you have to be very cautious in that setting. Okay, so we're going to stop there. That's the algorithms, and then Dr. Eichenfield is going to summarize for us.
Thank you, Tony. That was excellent. So what we attempted to do today was really to sort of give our introduction to the pediatric acne guidelines and initiatives. So summary points to take away. We know that acne in the pediatric years is incredibly common. That it clearly has a significant impact on affected individuals. We didn't go through the data today, but it's well known in terms of the psychological impact of acne in the pre-adolescents and adolescents can be quite significant. We're hopeful that the expert recommendations and guidelines will be helpful in managing acne in the pediatric population. There's a lot that wasn't discussed today that will come out in publication, including the approach and identification of and distinguishing neonatal acne from infantile acne, the approach to the management of acne in the younger childhood ages, the essential normalness of pre-adolescent acne in our 8, 9, and 10-year-olds and an approach to managing that. And in the future, we hope that there will be the publication of the guidelines shortly, similar lectures, as the Acne and Rosacea Society has been behind this, and there will be lectures such as this, as well as this lecture going online for other people to see it, as well as webinars about pediatric acne in the future. And we also hope, and certainly the faculty here tonight are very dedicated to future research, because we really need focused research on pediatric acne, so we can give you even better ways to take care of pediatric acne in the future. I thank the faculty for their participation, and thank you all for coming tonight. We will have some questions shortly. Thank you very much.